remember about 2 weeks ago, we spent a little time talking about the portal vein, the hepatic portal vein. Remember, we traced the vasculature from the superior and inferior mesenteric veins up to the splenic vein where it joins them. It makes the portal vein. That portal vein then joins with the right and left gastric vein, and they run into the liver and then split into the left and right portal veins. On the other side, it comes out as the hepatic vein, which goes to the inferior vena cava, which goes to the heart and throughout the rest of the system. Okay, I'm only running through it that quickly because we've gone over it. No worries if you excuse me, if you haven't memorized it yet, just get it off of the PDF. So after we went over that, keeping in mind that the point of the hepatic portal vein was to take oxygenated venous blood from anything that entered the stomach and take it through the liver so it could cleanse it, and then send it through the rest of the body, to the heart. Now, when we talk about the portal vein and the hepatic vein, one of the anatomic structures, well, it's an anatomic structure, but we talk about it because of its physiological capabilities, and that is the portal triad. So the portal triad is made up of the bile duct, the hepatic artery, and the portal vena. But keep in mind, this is a structure, and we're talking about it as if it has its own job together. And it's just a way of talking about physiologically what is happening between the liver and the rest of the body. This structure is actually found if you were to take the liver and take one of the lobes and dissect it into lobules. And when you look at those lobules, then you'll find, and I'll have a nice histological slice here. If you were to look at those lobules, you'll find these three structures there: the bile duct, the hepatic artery, and the portal vena. Okay? Let's take a look. So the idea here is that the job of the portal triad, the hepatic artery is going to carry oxygenated blood to the hepatocytes, the liver cells, while the branches of the portal vein are going to carry blood from the small intestine. Okay? So the idea is that not only do you have deoxygenated blood coming from the stomach that's full of nutrients, you also have the hepatic artery taking oxygenated blood without so much as many nutrients, but it's going straight to the liver cells. This is what it looks like. We'll find a nice color. Okay, so here's the bile duct. Not really a color I can use here. So in the bottom left-hand corner, there's a triangle with the base on the bottom of the screen. To the left in green is the bile duct. The apex is going to be the artery. And I would really like to draw on here. Let's get rid of that. Okay. Let's try a different. Okay. Okay, well, we'll just use the same color. So the bile duct, the hepatic artery up here at the 12 o'clock position, and then the portal vein or venule down here at, I don't know, call it 5 o'clock or 3 o'clock position. Okay? So that is the triad. And keep in mind, there's actually more structures to this. There's about 5 structures. But we keep calling it, you know, they've added 2 other structures since then. But we talk about it just as a portal triad. All right? Now, we will bring this into play a little bit later when we talk about perfusion to and from the liver and to and from the rest of the body. Okay? All right, so let's talk about some more vessels that are going to be present in the abdominal area. Henry, I did not pronounce your name. Everyone, everybody, I want you to know Henry is in the house. Sorry about that, Henry. All right. Shouldn't the artery have a bigger diameter? Wonderful question. I mean, let's think our way through it. And when you're saying diameter, let's go back through it. So the idea with arteries and veins, right? The job of an artery is that it is going to operate under high pressures. So if it's going to operate under high pressures, it needs to have not only smooth muscles, but also, other than the smooth muscles, it also needs to be able to have connective tissue inside of it to withstand the pressure. So my point is that the arteries are going to have, as a whole, a smaller diameter because they need to have thicker walls. Right? If we went outside edge to outside edge, let's just pretend we have two vessels, an artery and a vein, outside edge to outside edge diameter. Now, let's just consider their job. Let's start out with them equal. Then let's consider their jobs. If the job of the artery is to withstand higher pressures, it needs a thicker wall as we move inside toward the center, which is going to make the diameter, the inside diameter, smaller. The vein, it's under low pressure. It's just returning stuff to the heart. It doesn't really have to handle a lot of pressure, and so it can have very thin walls, and thin walls translate into a larger interior diameter. All righty. And thank you, Deborah. And Deborah brings up the point, low pressure in the liver. Okay, so let's talk a little bit about unpaired abdominal aorta branches. As you look at the abdominal aorta, you leave the heart, the left ventricle, go to the aorta, and then go out to the systemic circulation. You have the thoracic, which turns into the abdominal aorta. So at about the level of T12 is where the abdominal, the celiac trunk, we're going to call it. At about the level of T12 is where the celiac trunk rises. And you'll remember that in some of the pictures that you've seen. There's like this little, it looks like a little Y that's stuck on the abdominal aorta. I'll show you a nice pretty picture in a few minutes. So the job of the celiac trunk is, one, it supplies the lower one-third of the esophagus. It perfuses the stomach, first and second parts of the duodenum, pancreas, spleen, liver, and the biliary system, right? Got a lot of jobs to do. We're going to break those down and look at some of them individually, okay? So if we take the celiac trunk and then break it down into those I said it looks like a Y. So if we look like, each leg of that Y, one of them is going to be the left gastric artery, the common hepatic artery, and then the splenic artery. So think about it. We're still in the same neighborhood, right, as when we were looking at the hepatic portal system. We were looking at the left gastric vein. We were looking at the hepatic vein, and we were looking at the splenic vein. So we're still in the same neighborhood. It's just that we're looking at the other side of the blood flow. Now, talking about the left gastric artery by itself. The job of the left gastric artery is to supply the distal esophagus and the lesser curvature of the stomach. And we'll also find that that left gastric artery is going to have an anastomosis with the right gastric artery. Then there's a splenic artery, which not only supplies the spleen, as you would guess by its name, but also the body, not the head or the tail, but the body of the pancreas. Okay, so here's a nice photo. All right, let's get oriented here. Let me see what's going on. Here we go, celiac trunk. Excuse me. So we got the celiac trunk up here, and it's coming off of, let me move my thing here. This is going to be abdominal aorta that I'm tracing out in red. And then as we go lower, the first thing we hit is the celiac trunk, which is going to have that Y coming out of it, right? One of those is going to be the common hepatic artery. One of those is going to be the superior mesenteric artery. And one of those is going to be the splenic artery. Okay, so keep in mind that when we're talking about mesenteric arteries, let's define the word mesentery first. A mesentery is a structure that is responsible for fixing the intestines to the back wall. Okay, now that mesentery itself needs blood supply. So if we cut out blood supply, the perfusion to the superior mesenteric artery, that means that the intestines themselves will lack blood supply. All right, we'll talk about a few cases of those as we make it farther and farther. Okay, and I'm still tracing the aorta here. And as we work our way down to the feet, now we have the inferior mesenteric artery. And the difference between them, the superior basically handles all of the perfusion. If you start from the esophagus, well, actually, you know what, start from the stomach, I'm saying, sorry. If you start from the stomach and work your way through the duodenum, the jejunum, the ileum, the small intestine, the large intestine, the superior mesenteric artery is responsible for providing all of the perfusion through all of the intestines and going up to the proximal 2/3 of the transverse colon. That's as far as you want to go with the superior mesenteric. The inferior mesenteric provides the perfusion from the distal 1/3 of the transverse colon all the way down to the rectum. So if you're going to cut out something, if you're going to lose perfusion, what you'll find is you're going to have a pain distribution that pretty much mimics the anatomic distribution of the superior and the inferior mesenteric artery. And we're going to talk a little bit at the end of the night about the nerves that innervate these same areas. All right, so superior mesenteric artery, this is just the narrative to what I just said. Let's see. Arises at L1, I didn't mention that. And it supplies the gut from the second part of the duodenum as far as the distal 1/3 of the transverse colon. So there is a watershed or an overlapping, if you will. You'll find some sources that will say the distal one. Okay, yeah, some of medicine is medicine, some of medicine is language. So when I say the proximal 2/3 of the transverse colon, I'm hoping that you can appreciate it's the same thing as saying all the way to the distal 1/3 of the transverse colon, right? Or the last third, okay? So if we go to that last third, everything proximal to it is superior. Everything distal to it is the inferior mesenteric. So don't let the language throw you up. The point is, the first and the second third of the transverse colon are supplied by the superior mesenteric, and the third, if you will, is supplied by the inferior mesenteric. And right where they do some overlapping in that transverse colon, right at the point we call it the splenic flexure because there's the spleen, there is some overlap, not only on perfusion there, but you'll find some overlap when we start talking about the pelvic splenic nerves that also overlap right there. So don't be surprised if when you have pain there, that the referred pain, which we're going to talk about, is not clear and clean cut because there is a watershed overlap area there. All right? So let's talk about the inferior mesenteric. It arises at L3, so we're just talking 2 levels lower, right? And again, it starts from the distal 1/3 of the transverse colon, turns the splenic flexure, goes down the sigmoid colon, and then into the rectum. If you want, a lot of people, I had at least 2 questions on how to memorize the difference between rectum and anus. So, when you're coming down the patient's left-hand side and you have the sigmoid colon, it's called sigmoid because it has to make an S so that it can curve back over into the rectum. And the word rect, the root, means straight. Okay? So you come from a sigmoid structure, that descending colon on the left-hand side of the body, and then you come into a straight structure, the rectum. And then you exit the body with the anus. All right, let's see what else we got going on. Okay, so I'll show you a picture of this, but right now, for the next 2 slides, I just need you to imagine there's something called the Nutcracker syndrome. And the idea is that you have the superior mesenteric artery, right? We start out at the abdominal aorta. You come down to where I just showed you, where you have the celiac trunk. One of the 3 vessels coming off of that celiac trunk is the superior mesenteric artery. That superior mesenteric artery squeezes between it and the aorta. It squeezes the left, well, here, I'll show you. I think I have the picture. It squeezes the left renal vein. You remember we spent a lot of time on doing the anatomy of that left and right renal vein as they come off of the inferior vena cava and they go over and go posterior to the renal artery and enter the kidney. Right where that renal vein comes off of the inferior vena cava. Remember, the inferior vena cava is to the patient's right of the patient's abdominal aorta. So when that renal vein travels to the left, that left renal vein travels to the left, it travels in between the abdominal aorta and the superior mesenteric artery. And when it gets caught in between there, it's called the Nutcracker syndrome or effect. Okay, here's a nice pretty picture. Let me get my marker out. So, right, we have abdominal aorta going on right here. Here's the celiac trunk. I'm circling that in green. Okay. So as we drop down below from the celiac trunk, the first thing we hit is the superior mesenteric artery. See how the superior mesenteric artery comes anterior to that left renal vein right here. So you can appreciate that if you get situations of hypertension, how you can get that left renal vein squeezed in between the superior mesenteric artery and the abdominal aorta. And what are you going to have? You're going to have an acute kidney failure. And it's not because you have anything wrong going on with your kidney. It's just because you don't have any perfusion going on. All right? You can see how that cannot happen with the right renal artery because it doesn't, it doesn't go beneath anything to be squeezed upon. So the moral to the story is patient with hypertension and maybe some kind of anatomical anomaly that you can appreciate on imaging. They come in, they have an acute renal failure, and you don't have anything else going on. Think about Nutcracker. All right, let's take another peek here, make sure I don't have any questions. All right. While we're here, there's some other stuff we can point out, right? Let's see. Phrenic arteries up here, those are going to go to the diaphragm. Little ditty there is C3, 4, and 5 keeps the diaphragm alive. So that's the innervation of it. Let's see what else is going on here. Here's the inferior mesenteric artery. So you can appreciate how this one, the superior, like I said, is going to take care of the perfusion from the duodenum all the way to the proximal 2/3 of the transverse colon. And then this one, the inferior mesenteric, which is inferior to it, takes up and handles it the rest of the way to the rectum. And as far, oh yeah, the right common iliac artery and the left common iliac artery, I know it seems weird, but those are considered part of the abdominal cavity. When you look at them, they look like they're a lot lower. But just remember, the right common and the left common iliac arteries are part of the abdominal cavity. As a matter of fact, at the point that they bifurcate, when you are palpating the right and left lower quadrants on your patient, you would be able to feel, F-E-E-L, you would be able to feel a pulsating mass there if you had some kind of issue going on. Okay, so the second syndrome, we just talked about the Nutcracker syndrome. Let's talk about the superior mesenteric artery syndrome. Now, when I talked about Nutcracker, let's start from the same point of reference. With the Nutcracker, it was the superior mesenteric artery and the aorta, which were compressing something between them. With the Nutcracker, that something was the left renal vein. Same thing here, guys. With the SMA, the superior mesenteric artery syndrome, we're still talking about the superior mesenteric artery and the abdominal aorta compressing something between them. It's just a different something. This time, it is the third part of the duodenum. Okay, so you can imagine what the repercussions of that would be. Bottom line is you're going to have decreased transit time. Let's imagine we eat food, comes down our esophagus, goes into our stomach, it moves out of the stomach, peristalsis. It tries to make it through the duodenum. Oops, can't make it there. What's going to happen? We're going to have regurgitation back into the stomach, back past the lower esophageal sphincter, back up into the esophagus, and your patient comes in and say, hey, I got a heartburn. All right. So there you go for the SMA syndrome. Now, let's talk about the diaphragm. There are three, count them, three things that pierce the diaphragm. I put them in order, in a cute little order that you can remember them, in the order of vowels, but it goes from inferior to superior. So we're traveling bottom to top as we're saying A-E-I. Okay, so aorta pierces the diaphragm at the level of T12, the 12th thoracic vertebra. The esophagus pierces the diaphragm at the level of T10, and then the inferior vena cava does so at the level of T8. Okay, let me take a peek, see if I got any questions over here. And let's see, Stephen, we got a question. How do you treat the patient? I'm sorry, I don't know which malady that came up on. I just read your question. I presume your question applies to either the Nutcracker or the SMA. Actually, it doesn't matter which one. I don't know how they treat them on either one. I can find out for you, though. Because I don't know if it manifests strictly as an anatomical anomaly in a patient, or if it manifests as a presentation of some other pathophysiology that's developed during our lifetime, like high blood pressure. That I don't know, and it should be an easy answer to find. So SMA, okay. All right, well, ball's in my court. I'll get you an answer on that. All right, anterior abdominal wall. We all like to talk about it. We all like to remember it. We get all wrapped up into oblique and external and internal. And guys, I can't tell you that I've had one question on my board review banks on this. But I'm going to go over it more for the sake of talking about inguinal hernias, less for the sake of knowing the levels of the abdomen, okay? So we have the rectus abdominis, and we have the exterior and interior obliques and the transversus abdominis. So we're going to talk about them. That's all I'm going to say about them until we get to the picture where you can actually see it when we're talking about hernias. And here we go, hernias. So let's talk about the umbilical hernia. So the umbilical hernia is not something that is acquired. It is congenital. You only treat it if it's greater than 2 centimeters, and it is most common in African Americans. Okay? Separate from the umbilical hernia is the inguinal hernia. I'm mentioning here the inguinal canal because the next, I don't know, maybe 5 slides, guys, are it's a topic that, for whatever reason, it's really, really easy to get mixed up on if you put it in your head the wrong way the first time. So I want to try to make sure that I get it to you the right way the first time so you don't have to unlearn anything. One of the things that you'll have to use as a baseline reference for talking about the difference between the 2 types of inguinal hernias. Remember, there's a direct and an indirect. I'll give you cute little ditties to get them right on the test, but I want to make sure that you actually know what they look like. So one of the main structures that we have to refer to when we're talking about them is something that's called the inguinal canal. So the inguinal canal is just a tunnel where you have all these structures that pass through the abdominal wall. And one moment, I'm going to have to make a quick adjustment here. So remember the inguinal canal, it's nothing more than a tunnel, and you're going to have all these abdominal structures going through it. And the male canal has something different in it than the female canal. You would expect that, right? The male canal is going to have the spermatic cord. The female canal is going to have the round ligament of the uterus. Now we're going to switch to talking about the male because we're talking about inguinal hernias. So when we talk about inguinal hernias, there is a landmark triangle. It is called the Inguinal Triangle. It's also called Hasselbalch's Triangle. Okay, either one of those names you would see. The idea is we're looking, as you're looking right now, you are looking, the patient is facing you. And I've tried to draw these structures roughly at the angle that is anatomical, but not a good artist, not very good at PowerPoint. So I've got nice pretty pictures to show you. All right, so 3 sides of the triangle, of this inguinal triangle. Let's start over here. You're going to have something that they call the conjoint tendon. As we work our way clockwise, you're going to have the inferior epigastric artery. And coming around to our 6 o'clock position, we have the inguinal ligament, okay? Now, this is one of those things you just have to, like, rote memorize because like, none of the words relate to each other. You know how you usually could say something's superior and something's inferior. You know, if you look at the first word, it's conjoint, and it's inferior, and it's inguinal. If you look at the second word, it's tendon, then there's an artery, and there's a ligament. It's, there's really nothing to relate it to. These are 3 very varied and diversified objects that we happen to be using together to identify an area that we're concerned about when we want to try to name a direct or indirect hernia. Yeah, let me just take a peek, see if I got any questions. Nope. All right, so now that we've identified the 3 borders of the inguinal triangle, now I'm going to put it in an anatomical space for you. So let's talk about This is the same three they were talking about, right? So we have here the inferior epigastric artery. I am surrounding that in green right now. Let me do it in red or blue. Let me pick blue. Okay, so the inferior epigastric artery right here. Okay. I'm going to pick a different color to do that conjoint ligament here. Okay. Hope you can appreciate it going just right there. And then, what's a good color? I don't know. Cyan. Okay. So this green area here that you see highlighted is the triangle to which we're directing our attention. And hopefully you can appreciate the three borders. Like I said, it's difficult because they're just three different structures, right? It's an artery, there's a ligament, it's just three totally different things going on. All right, I have a different photo of it right here. Still talking about the inguinal canal. I'm going to get out my pen here. Okay, so I'm tracing in blue now that ligament, the inguinal ligament. Now I'm going to trace in red the inferior epigastric artery. And then in a third color, right here, you can't quite see the conjoint, but they have a muscle here. I don't know why they put that there. Okay, let's go to another. All right, so here's the one. This is the only reason we really need to talk about the layers of the abdominal muscles. Because if you don't go down deep enough to make your way to the conjoint tendon, then where you're going to be is really superficial, and you're going to be looking at the rectus abdominis. All right. That said, let's identify the triangle. All right, so we have here the inferior epigastric artery, rectus abdominis here, and over here, just because they're up more superficially, they're pointing out the iliopubic tract. Okay, now do not let that throw you off. This picture is simply coming more superficially. What I want you to be concerned with is Hasselbalch's triangle. You stay deep. You only look at the inferior epigastric artery and the conjoint tendon. Just pay attention to those and stay deep. This is useful because they're showing this is a landmark for the ductus deferens. Ductus deferens, and but more importantly, the vas deferens is what you have to locate when you're giving a vasectomy. Okay, so now that we know where they are, let's do some definition. All right. Okay, so I've got two ways for you to memorize this. Let me just take a quick time check here so I see what's going on. Okay. I've got two ways for you to memorize this. One of them is in the old Golian, remember one and the other one's the other one. Okay? So we'll do that first. And then the other way is just going to be a very simplified way. Okay, let's start with the, remember one and the other one's the other one. With the inguinal hernia, the indirect, what I've done is I've taken as many repetitions of IN as I can. So with the inguinal hernia, indirect, that is going to run inside the spermatic cord, and it's found most often in infants. IN, 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 okay? It also runs through the internal inguinal rings. So you got like, what, 1, 2, 3, 4, 5 INs there, right? Okay, so, you know, you're starting on a test question, you see all these words with IN, it should be a really big clue that they're talking about the indirect. Now, and that is the most common. Between the indirect and the direct, the indirect is the most common. And then the other one's the other one, okay? Okay, so enough said about that one. Let's start with the other way that I want to show you how to memorize it, at least for board purposes. For board purposes, you're either going to have one that starts lateral to the inferior epigastric vessels or medial to it. If it starts lateral, it's indirect. And then the other one's the other one. Okay? If the hernia starts out lateral to the inferior epigastric vessels, and I know this, it's like 3 directions I'm giving you in one sentence, right? Lateral and epi is up top, and the inferior epi is the bottom one. I know, I'm sorry. I didn't name the part. But if it starts lateral, if that hernia starts lateral to the inferior epigastric artery, then it is indirect. Okay? Let me just peek over, see if we got any questions. Okay, got nothing. All right, so here's a picture of this one. On this picture, you cannot appreciate the laterality of how it starts. You can appreciate the other stuff that I told you. The first one, remembering one and the other one's the other one. This indirect inguinal hernia. So here's the ring. This is the inguinal canal, right? We have a internal ring, external ring, which establish the canal. So the hernia is going through the canal, and then it goes, I'm going to trace the spermatic cord. This is the spermatic cord which leads down into the testicular sac. That hernia, that bowel actually goes through that spermatic cord. And then that's the danger of it, guys, right? Is that the bowel is going to push its way through that spermatic cord and then into the testicular sac and cut off blood supply to the testes. And you can have some kind of torsion going on down there, all kinds of problems. So, you know, that's the big worry about the indirect. All right, so have no questions. Good. All right, so I'll move on here. All right, so we've talked about the indirect. Let's talk about the direct. The easiest way to spot it for test and board purposes is it's going to be the one that runs medial to the inferior epigastric vessels. Okay. Now remember, the vessels that we're talking about are paired. So in order to know what's lateral and medial, you have to remember which is the medial side of the triangle. Okay, you have to flip it as you go to the other side. So with the direct hernia, starts out medial. It goes below the fall inguinalis. We will not have to pay attention to that. It is outside of the spermatic cord. So we're not really worried about it descending into the scrotum. And the way that I remember it is through this little ditty here. This one I made up just as a short route. The direct hernia, it goes directly to the superficial ring. That indirect hernia, it still gets there, but it travels indirectly. It's got to go through the interior, the exterior ring, go through the canal, go through the spermatic cord. It leaves there, comes through the abdominal wall, goes into the scrotum. So it's like a long, convoluted, tortuous route to get there. The easiest way, at least for me, which I like to encourage you to remember, is direct hernia goes directly to the superficial inguinal ring. It does not make all those turns. That's how you remember where it ends up. You know, but you're going to know it when you see it, right? You're going to know it because it starts out medial to the inferior epigastric artery. The indirect hernia is not going to start out medial. Wherever it ends up, it's not going to start out medial to that inferior epigastric artery. All right, let me take a peek, see if I got any questions. Good, no questions. Okay, so we've got a nice little cutaway here. There's no hernia, but I'm going to draw one. I'm going to draw a direct hernia to show you where the intestines would go. So this area here, we haven't pointed it out, though I've talked about it. When I say superficial ring, that's right here. Okay. Here is that rectus abdominis muscle. The only reason we really need to talk about the stomach. Okay, so that is the lateral wall of the triangle. Medial wall. That is the medial wall of the triangle. And let's find the inferior epigastric artery. It's going to be running through here. And then the inguinal ligament here, which means that all of this green area is what establishes Hasselbalch's triangle. So if we created a direct hernia, the point is it's just going to come out right through here. Okay? It would start out medial to it, to the triangle. And I'm going to have to switch colors. And then come out way over here. Okay? But it does not travel through the spermatic cord. All right. Those are hernias. So just go over that a few times, you know, and especially when you key off of the origin of it being lateral or medial to the inferior epigastric artery. I think the rest of it will be either easy or unnecessary as far as having to appreciate it. Let's talk about testes. Why? Because when they're undescended, they're in the abdomen, and we're talking about the abdomen. So, for test purposes, undescended testes 100% of the time will end up cancerous. 100% of the time. Let's see. Got a question. For purposes of illustration, indirect travels through the cord, direct next to the cord. Yes, you can say that. If that is the way you would like to remember it, I totally encourage you to pick something. And when I say pick something, to pick, how do I want to say this? When you're memorizing things, you have to be able to choose the verb and the object and the subject that works for you. And it has to work on both sides, and it has to work when you switch and talk about the other thing. So what I'm getting at is if the object of your verb is going to be that spermatic cord, you have to remember that you're using the word, what are you using? Through and outside. So interior and exterior. You have to go through your mind in a thought experiment to see if you can leave the sentence the same and just change the verb, the direction. Is it going through? Is it traveling through, or is it traveling outside? I don't know if it works. If it does, and it works for you, keep it. I went through a whole bunch of words to figure out the easiest way. And for me, it was superficial inguinal ring. It either went directly there, didn't make any U-turns, any, crazy, tortuous detours. It went directly there, that was the direct, or went indirectly there, and that was the indirect. If you can do that as simply talking about the cord, then drive on and more power to you. All right, so undescended testes, 100% of the time cancer. And the thing about testicular cancer is that it tends to spread to the aortic node, and it does that by traveling through the testicular artery. And it's kind of a weird thing, but the right versus the left testicular uh, lymphatics travel different routes as they go back up. We'll talk about that a little bit more later. And it is why you'll find that one laterality, one side of testicular cancer tends to be fatal faster than another. They both will be fatal. It's just that one has a more direct route to the heart. So, and the reason is this bottom statement, that the lymphatics that are coming off of the testes, they reflect their developmental origin when they used to be retroperitoneal, more truly retroperitoneal and attached to the posterior abdominal wall. So they moved, but the passageways, the lymphatic passageway, reflects more where they started out than where they ended up. So it's just one of those weird things. It is not one of the things that you need to visualize and remember what it looks like in the same way that you needed to do the hepatic portal vein. It's just one of those things you need to remember, that the right testicular cancer metastasizes faster than the left to the aortic node. Okay, so let's talk about this word retroperitoneal. You will find two ways of talking about retroperitoneal organs. First way, people will say that they are primarily retroperitoneal and secondary retroperitoneal. The second way, the alternative vocabulary that is used, is that something is true retroperitoneal or retroperitoneal. Okay, I prefer primary and secondary because you find this same language with HEPA filters, guys. When you go to Target or wherever you shop, you're going to see HEPA filters and true HEPA filters. There's retroperitoneal and true retroperitoneal organs. I think it's a lot more clear to just say primary and secondary. Those things that are primary are those things that are only covered on one face, versus those things that are secondary that might be covered on, covered all the way around. Some are covered on two faces. Some might be covered all the way around. I think I have a nice, pretty picture here. Well, before I go forward, primary or suprarenal glands, kidneys, ureter, inferior vena cava, and abdominal aorta. So if they are covered on one face by mesentery, they are primary. If they're covered on more than one face by the mesentery, then they are secondary. Let me divert, see if I've got any questions. Are you saying that all of it is cancerous? How about those which undergo surgical intervention? Yes. Yes and yes. What I'm saying is without surgical intervention, all undescended testes will proceed to cancer. So no intervention, 100% chance, cancer. Alrighty. And I see these say it again, but I'm not sure what that applies to. You want me to re-explain retroperitoneal primary versus secondary? Is that the question? Okay. So you have, let me just see if I have a picture of it here. No, no picture on this one. It's in the anatomy class. So with the organs that are in the abdominal cavity, some of them are covered on only one face by the mesentery. Some of them are covered on more than one face. If it's only one face, then we call it true, or we call it primary retroperitoneal. And the real idea behind this is that if you're going to be true or primary, it implies that you're attached to the posterior wall. So think about it. If you're attached to the posterior wall, then you can only be covered on your front face. You could be behind the peritoneum, however, have a peritoneum that runs around the viscera. You know, the more forward you are, like the duodenum. Duodenum, if you take a sagittal cut and you look at it, you know what, let me get a picture for you guys. So I know I have one moment. It's easier to see in a photo. Let's see. I think I can find this quickly. Not there. Just one moment. If I don't find it in 10 seconds, I'll just show you on the next session. Alrighty. So, sorry, I'll just show it to you on the next section. But I have a nice little sagittal cut of the cavity. But the take-home point is covered on one face and attached to the posterior wall, you are true or primary retroperitoneal. Covered on more faces than one, or if you're not attached to the posterior wall, you are secondary retroperitoneal. Alrighty. And let's see, where does that take us? Let's see. One face would be the rectum is an example of something that's true retroperitoneal. It's only the anterior face comes into contact with the peritoneum. So I'm sorry, it's definitely going to be one of those things that's easier to show you. So I'll put that in the front of the next section and show you, because I have the picture, just don't remember which lecture I have it in. So I'll make sure that's the first thing we'll talk about in our next lecture. And I'll show, once you see the picture, you'll say, oh, I see. Okay. And Stephen said there's an excellent YouTube, gotta love YouTube, video that pictures the peritoneum. And you can find anything on YouTube. All right, so that takes us to, let's see where a good stopping point is. Yeah, this will be a good stopping point. We're going to talk about, no, we'll go 2 more slides. We're going to start nerves, because that's going to be a little heavy lifting mentally, and we'll finish it up on the next section. So, abdominal vessel, we're still talking about the abdominal vessels. Let's talk about the celiac artery. Not the Celica, that's a Toyota. The celiac artery, the superior mesenteric artery, and the inferior mesenteric artery. Their jobs are to perfuse organs in these particular areas. So the celiac perfuses organs that are in the foregut. The superior mesenteric perfuses those organs that are in the midgut, and the inferior mesenteric perfuses organs that are in the hindgut. And we are going to chat about that again when I show you 1 or 2 pathophysiological representations. All right, that takes us to nerves. Let's see where we are. 4 minutes to go. I can talk about 1 slide, I think. All right, so let's just get our brains prepared for nerves next week. Just like when we talked about the superior mesenteric artery was responsible for perfusing everything from the duodenum to the proximal 2/3 of the transverse colon. Just keep that same line of thought when we start talking about nervous innervation. The nerves, we start out with the vagus nerve. The vagus nerve is responsible for innervating the distal esophagus all the way to, the proximal 2/3 of the transverse colon. Okay, so you almost have an exact overlap of the perfusion map when we're talking about the nervous innervation. So you can probably guess that there's something else that is not the vagus nerve that's going to take over at that distal 1/3. And again, there's going to be watershed. There's going to be overlap at that splenic flexure where the transverse colon changes into the descending colon, or the sigmoid colon, also known as. And that something is going to be the pelvic splenic nerves. Okay? I'm going to leave it at that because it's going to take about 5 slides to explain what that is. But right now, I want the take-home message to be that just like we have perfusion responsible for certain areas of the GI system, it's almost an exact overlay of that map when we start talking about the nervous innervation of that system. So you guys have done it one more time. You have wasted 90 minutes of your life with me. I hope it was fun. It was fun for me. I only have a couple of days left in this place they call Fort Bragg. I'll be back to civilization, and I will look forward to seeing everybody's happy, bright, shiny face. Okay, guys, so I will see you in about 6 days and, I don't know, 20-something hours. So for those of you who are enrolled in the USMLE Step 1 class, I'll see you in about 15 minutes. Until then, have a great week, guys, and a better weekend. Bye-bye.